session, which is Nutrition and Oncology. Our session director for the session is dietitian Anjali Nair, senior nutritionist and dietitian Mumbai, and our chairperson is Dr. Shiv Shankar T, nutritionist and dietitian from Mumbai. So now I invite our session director to please start the session and also to talk on nutrition assessment. Over to you, ma'am.
Good afternoon, all of you. I thank the organizers to invite me for this session today, where I'm talking on nutritional assessment with a case scenario. In my many years of experience, and also today with many scientific evidences, they do state that both cancer and the oncological therapies which are utilized for its treatment can have profound effects on an individual's nutritional status, thereby making nutrition an important component of medical care. Although all patients with cancer are at nutritional risk, as evidenced by the screening, not all patients with cancer can become malnourished. And therefore, first by having the screening done and then using nutritional care process, which includes nutritional assessment, ongoing monitoring and follow-up, are crucial for preventing or minimizing the development of malnutrition at all stages of treatment. Also, it has been long known that patients with cancer experience weight loss and tolerate treatment poorly. Poor nutrition status has been correlated with decreased long-term survival and a factor in exhibiting lack of improvement in treatment outcomes. So now, as a clinician and an onco-registered dietitian is responsible for assessing the nutritional status of patients with cancer, having an understanding of potential metabolic impacts of various tumor types and also the possible effects of various oncotherapies. So in most of the cancer hospitals, I'm sure it goes with the help of a rehabilitation team, including of an oncologist, an onco-nurse, a dietitian, a therapist, and patient's relative and the patient, which help in identifying the nutritional goals and plan ways to help meet them. Today, all the doctors or the oncologists, along with the dietitians as panelists who are present around, will definitely agree that eating well on treatment helps the patient to feel better, keep up the strength and energy, maintain weight and the body store of nutrients, better tolerate the treatments related side effects, lower the risk of infections, help in healing and faster recovery, thus helping in maximizing the quality of life. Now, for that reason, the regulatory agencies like the Joint Commission on Accreditation of Healthcare Organization and Centers for Medical Care Services require the nutrition screening be performed in all healthcare setups. Nutrition screening refers to the initial clinical evaluation to identify the patient who is risk for malnutrition. Accurate nutritional screening is a vital support to nutritional care process, and it is not considered as a part of a nutrition care process because it can be conducted by any healthcare professional, and this can be done the moment patient is registered at the hospital level, so that whoever is an healthcare professional can definitely screen this patient. When we talk of screening, it is found that MST is an example, that is malnutrition screening tool, is an example of short nutrition screening tool, and it has been validated in both inpatient and outpatient settings. It has been found that this is highly sensitive and low specific in cancer patients. Now, if you see, this is a format which is used in MST, and it states that whether you have lost weight recently, how much you have lost, and what is your appetite. Whether you are eating poorly, that shows your appetite score. So this total malnutrition screening tool score is only based on weight loss and your appetite score. And it says that if the score is 2 or more, the patient has to be referred to the registered dietitian immediately, so that the dietitian takes part in the nutritional assessment of the patient, giving them with taking the dietary recall, and this helping them to give the proper nutritional interventions. Next slide. Now, as in malnutrition screening, if the patient is at low risk, routine clinical care is given, but the screening is repeated again. If it is at hospital, maybe a weekly screening is done, or if the patient is asked to come for follow-up after 15 days, maybe during that time it is done. And at home care, it can be monthly, and in community, it is done annually. But after screening the patient, in case we find that on dietary recall, if we find that the patient's documentation of dietary intake for 3 days is lower, and if inadequate diet is being taken, that is by considering the appetite score, you can immediately repeat the screening again, and again, as it is said, weekly, home care monthly, and community annually. But at medium risk, immediately after every 8 days, the screening can be done and will help the patient to understand, and after taking the dietary recall and starting on the dietary interventions. But if the patient is at high risk with 2 or more score, immediate reference to the dietitian by the clinician is important for nutritional interventions, and this dietitian can help the patient to set goals for his dietary intake. Next slide. Now, many a times it is asked that why is it MUST, that is malnutrition universal screening tool, is not effective in cancer patients. As studied with MST and MUST, it is found that MUST is with low sensitivity and high specificity, and this is more helpful for the patients with other chronic diseases. Now, main thing in MUST, the addition of BMI score is there. Now this, when BMI score, many of our cancer patients, it does happen that they are edematous, they can have swelling on their feet, they can, it can be hyponatremia, it can be hypertension, or it can be hypoproteinemia, because of which the swelling is there, and where the BMI score differs. So for that reason, it is found that MUST is with low sensitivity and high specificity. Next, so it can't be used for in the onco patients. Next slide. after screening of the patients, after sending the patients or referring the patients to a dietitian, a registered dietitian, it is that person who does nutritional assessment for this patient, for the patient. And it is found that using SGA, which is a subjective global assessment. And this subjective global assessment is a validated tool, especially for cancer patients. And I think in 1995, 1996, this was done by Dr. K. Mohandas, a gastroenterologist, along with Mrunal Shirodkar, and it was found that it is a most validated tool for cancer patients because this was initially developed to assess patients for malnutrition by utilizing the information that could be obtained without the need of laboratory data, and it is the one which integrates many traditional parameters used in nutritional assessment with clinical status and functional capacity, and also deals with the historical information of weight loss, the dietary intake, GI symptoms, and functional capacity. It also has the metabolic demands underlying the disease and nutritional related physical examination considering loss of subcutaneous fat, presence of muscle wasting, edema, and ascites. So there are around about the score is between 1 to 7, and you can see we have very mild risk to well nourished, which is 6 or 7, mild moderate, that is 3, 4, or 5 ratings, and severely malnourished is 1 or 2 ratings in most of the categories. So on this basis, and with the help of dietary recall, it is the dietitian who actually plans on the nutritional interventions for this patient. And after giving the interventions, it is not where the dietitian's job is stopped, because the monitoring of the patient is definitely important, because we need to understand that the patient is actually following the diet plan or the dietary interventions which are given to him, so that he doesn't get into cachectic stage, and with cachectic stage he doesn't get into the last stage of his life. So that is why it is always important, from screening to nutritional assessment with nutritional interventions, which definitely helps the patient to take his treatment better and helps in giving a positive result. So, why this has been started? Because American Dietetic Association adopted this nutrition care process in 2003 as a framework for dietetic professionals to use and support critical thinking and decision making in variety of care settings. And the purpose of this was to improve the consistency and quality of individualized patient care and the predictability of outcomes, with a systemic approach to provide high quality care and standardized model intended to guide a registered dietitian in providing high quality nutrition care. So this nutrition care process is crucial to improve the consistency and the quality of individualized care for patients and improve the predictability of the patient outcomes. There are 4 stages, 4 steps, you can say. The first one is nutritional assessment. And this nutritional assessment is defined as a step which is a method of identifying, evaluating data needed to make decisions about nutritional related problems and diagnosis. Individuals with positive screening results can be referred to a registered dietitian for comprehensive nutritional assessment. And the data is gathered, which is clustered in nutritional assessment, is the nutritional history. That is where the patient talks of the type and amount of food consumed, changes in quality or the quantity of food eaten, maybe reporting the reasons why they are not able to, and achieved through the food record of 24-hour food recall, or and also calculating on the caloric and the protein count. Along with that, if possible, citing on the markers of nutritional status, that is serum hepatic transport proteins, albumin, free albumin, and transferrin, and the anthropometrics like the height, current weight, weight history, usual body weight, mid-arm circumference, and tricep skin fold. Also, while planning of a diet, it
Anjali,
is always essential to have the biochemistry
Anjali,
parameters into
hello,
account.
hello.
Hello.
Can I ask you to go to your last slide, please? The time is over. This is Purvish speaking.
Oh,
Thank-
Dr. Purvish. Yes, but I have to give the patients overview.
No, I think we have run out of time. We cannot continue like this. Please go to your last conclusion.
Oh. So this last conclusion, there are studies which are saying that patient is directly not linking only with nutrition screening, but to improve the outcomes in onco patients, you have to link between screening and the nutrition risk. And there are evidence of improved outcomes in severely malnourished patients with nutritional support. So early effective screening and early identification with proper nutritional assessment can have optimal nutrition intervention, which can help you to improve the outcomes, as evidence in the case which I have put up. Thank you.
Thank you, ma'am. We'll now move on to the panel discussion. I now invite Dr. Senthil Rajappa, medical oncologist from Hyderabad, to please moderate the panel discussion on the session. Problems on nutritional assessment. The panelists are Dr. Puresh Parekh, medical oncologist, Mumbai; Dr. Anil Singhvi, medical oncologist, Indore; Dr. Ghanshyam Biswas, medical oncologist, Bhubaneswar; Dr. M.V. Chandrakanth, medical oncologist, Kolkata; dietitian Nazneen Hussain, nutritionist and dietitian, Mumbai; dietitian Shilpa Chadda Thakur, nutritionist and dietitian, Faridabad; dietitian Meena Kumari, nutritionist and dietitian, Faridabad; and dietitian Ritika Sharma, nutrition and dietitian, Delhi. Apologies. And I also request the chairperson to please join the panel. Thank you.
Thanks, Kashish. Good afternoon, everybody. I'm doing a panel on something I've never done a panel on. Okay, Madam is a nutritionist, right? Very good. So the only wise lady of all of us. All right. So we're running a little short of time, so we'll finish. Pull it
Dr.
back.
Senthil, it is not the wise lady, but it is like with the experience of, and trying to help the patients out. And of course, there are more wiser people than me now.
Agreed, madam. Agreed. Absolutely. Okay. So, okay, our slides are up there. So I thought nutrition and cancer is very similar to Indian democracy. All of us want to go and vote. We know we should vote, but we don't vote. So we all know nutrition is extremely important, but we don't lay the necessary emphasis on doing that appropriately for our patients. So what I thought we'll start with a few numbers that will help us explain the gravity of the situation better. And a lot of this is actually Western literature. So even in well-to-do economies, 30 to 80% malnourishment, 10 to 20% of mortality is independent of the cancer and is very much dependent upon the nutritional status. In fact, there was a paper some years ago on just the impact of exercise and nutrition in adjuvant therapy of colon cancer, and it gave more benefits than what you get with adjuvant chemotherapy. So very important. And it's got impact on all these cancer outcome parameters, quality of life, adverse events, PFS, OS, resource utilization, because patients who are better nourished are likely to develop complications less, so your usage of resources is less. So Chandrakanth, overlooked, under-prioritized, under-diagnosed, under-treated, why is it that we are not emphasizing adequately on, or you're saying, I am doing, sir, only you are not doing? What is the reason that we are not focusing as much?
So if we look into cancer, the directly visible cause of morbidity mortality is cancer, which is visible. But nutrition, even though we consider it as the underlying cause, we are not realizing the direct causation. It is not in the consciousness when we see the mortality. We are blaming more of the disease than the nutrition part. So because we are not able to see that clear visibility of translation of nutrition to morbidity mortality, we are not able to perceive it.
Vivek?
Sir, actually, I feel that the problem is itself in the setup.
Okay.
As an oncologist, when the patient comes, we are referring the patient, you go and meet cardiologist, you go and meet dietitian, you go and meet surgeon.
So are you saying regularly we go and meet dietitian?
So, yeah, I
That's
mean,
the problem. That's the point I'm
yeah.
trying to ask
so
you.
multiple referrals, that is the reason why I think the oncologist, is reluctant to give multiple referrals, because the patient also is exasperated of going for. This is one point. And second is, sir, the referral itself to the dietitian is not adequate, because
Exactly.
most dietitians, they don't do a nutritional assessment and document a nutritional assessment.
If
I'm
Dr.
not-
Anjali Nair was able to throw something at you,
No.
she would have probably done that.
No, sir. In an institutional setup, that is different. But if you take into account most dietitians, do they do a proper nutritional workup pre-assessment?
Okay, we will come to that. We'll come to. So you're saying some practical problems are it involves too many referrals, and you're not in general very happy with what the nutrition does. Okay, fine. Point very well taken. Dr. Anil, you have some. I'll quickly run through Sir and Biswas before I hand it over to you for the rebuttal.
Yeah, just that we are not oriented that way. And as far as I can remember, we were not taught during MBBS, during MD. Nutrition was, I think, maybe about 30
we were
minutes.
concentrating upon
30
our
minutes.
nutrition, it looks like, but certainly not you and me.
So we are not oriented. And then the other thing is, in the back of mind, we thought, what can we do about it? Even if he's malnourished. So we didn't have enough tools or
Okay.
this thing.
Okay. Biswas, in your setup,
So I think that the onus lies on us. So the nutrition was a problem with the patient and the attendant every time. So probably sometime later now we have started focusing. So the problem was within us. So now we have understood the supportive treatment. So one of them is around in the nutrition is important.
Right. So you're slowly starting to realize. Okay. Sir.
I think if I am sitting in the OPD and looking at the patients, I have to think of what is the priority in the patient's mind. When he comes with the diagnosis of cancer, his entire focus is on, is the cancer diagnosis right, whether I am going to be cured, what is the treatment. So if we start talking about nutrition on the first consultation, I think it doesn't work, because the patient's family is not in a mental state of mind to understand what we are saying. So I think that once the diagnosis is over, once the treatment discussion is done, and between that and the actual initiation of the treatment, that is the time when nutrition discussion should happen. The investigations required for that should be done by that time, but the discussion should be initiated when the cancer-directed plan is very clear.
Correct. So you're just saying we need to prioritize, make 1, 2, 3, 4, and then say nutrition is there as part of this care plan, but it's not the one at the topmost. Madam, so Dr. Nair made the point saying, as soon as somebody is registered, this should be part of the plan. But there are some practical issues, though that's the ideal way, but there are some practical issues associated with it. So I want you to tell me about that and about what Vivek was actually referring to.
So I agree that one, we need more referrals. So I think the biggest thing is that the nutritionists are there, but sometimes the references are not there. So this entire phase goes undetected. I would also like to like Dr. Purvi said, I think that's a valid point that first time when somebody is detected, there's too much of chaos and even the family may not be in a position to hear. However, it can be a part of the regular testing which is done, because any which way the patient is going to come several times to do several tests. So I think nutrition should be a mandate, assessment should be a mandate there, because a lot of prehabilitation actually improves outcomes. So if we are able to work up, use those 2-3 weeks while the patient is actually getting tested for a lot of things, I think that's a very valuable time which we shouldn't lose out on.
Chandrakanth, as Madam is talking about it, have there been instances when you've said, surgery patients, they do it for surgery patients regularly, they admit them for nutrition, right? And then they take a week, optimize, and then perform surgery. Have there been instances where you've said, okay, somebody with ovarian cancer, sick, came, and then you said, let's admit this lady for 1 week of nutrition, and then her performance status is likely to get better, then let me start treating? Because somebody suggested to me when I said, my patients are all very sick. So he said, admit everybody, give them nutrition, get them better, start the treatment. So has that happened in your practice, sir, as you're thinking about it?
So, no, sir, I would, yeah. So my immediate decision will be to give a AUC to carboplatin than to think of nutrition. Okay. Actually, this is what I would think of.
So you're saying I will be able to deliver at least AUC2 even if somebody is malnourished.
This is what I will think as an oncologist. I don't think of nutrition as a priority in this patient.
Right. So such an instance has not come up in your practice at least. Dr. Ritika, Vivek said that we do send to nutritionists, but in his mind and his opinion, the assessment made is probably not the most appropriate and optimal. So what is it that you do in your hospital or clinic or wherever it is, Dr. Ritika?
Good morning, sir. Good evening to everyone. I work in a hospital, and yes, there are no such assessments used in the hospital as of now. But we make sure that whenever a cancer patient or any such patient we are being referred to or we are treating, we use a certain kind of assessment or screening for every patient. It gives a clear picture of how to take, a clear path in the nutrition. So I as a nutritionist in the hospital, I try to use the appropriate nutritional assessment and screening for each and every patient.
Okay. So how long does it really take to do this for one patient, Dr. Ritika? Let's say the tool that Madam actually shared. Sorry, please go ahead.
See, if we are doing it regularly with each patient, we know what exactly questions do we need to ask them. So it takes approximately like 7 to 8 minutes to fill the assessment form, and then we keep talking to the patient, keep a 24-hour recall of their diet and everything and how their lifestyle is, what all things they face when they are thinking of nutrition or when they are thinking of their medication. So yeah, it takes approximately about 7 to 8 minutes to fill an assessment for a single patient.
Okay. Dr. Meena, most of the tools that are available from whatever little I read up seem to be not validated to be used in cancer settings at least. So Madam did show a tool that she said was validated in Tata Hospital. So do you all use a uniform tool or everybody has your own ways of making that assessment? For example, I just see somebody and that's the way I make my assessment, which is unscientific, inappropriate, but that's what we do in practice. But since you're a specialist, do you have a pro forma that all of you share or you come to some consensus that this is what we'll be doing? Have you got something like that? Because it's easier to apply that across the country or across hospitals. I think, no, she is not muted. I think she can't hear me. Dr. Meena, are you able to hear me? Madam, you can take that question, Madam, Dr. Nair.
Yeah, I think it is like, I think now I can see Mr. Shivshankar around. So in Tata Memorial Hospital, again, I would say that the MST and along with that SGA is still followed, because as I said, it was a validated tool and to be used in Tata Memorial Hospital. So if everyone tries to follow it for onco patients by first screening and using SGA, I think it will be worth, because the patients after treatments who become cachectic will be taken care of before they become cachectic, so that we can have a better outcome and the patient is also able to feel that he is able to eat something and he is able to get his proper nourishment rather than relying further on TPN or something like that.
Okay. Biswas, in your practice, how frequently do you send patients for assessment? Do you send them on day one and then say, okay, let the dietitian or the nutritionist take care of this, or do you have some organized plan like that?
Started since last few years after attending so many onco nutrition meetings.
Okay.
So definitely.
I believe you are the president of the society also. Okay, so you leave it to them to decide how frequently you have to. So you, again, I'm asking you the same question. So you have a very busy practice, right? And then you go to the hospital. I mean, when I say hospital, medical college hospital and all that. So, you know, the problem sometimes I face is that we have half a dozen nutritionists and an outpatient that runs into many hundreds every day. And in my opinion, in our hospital, almost everybody needs some kind of a nutritional assessment, because the kind of patients that we see are not, you know, really well nourished. So there's always this number mismatch between people who are necessary to assess and take care of these patients. So does that happen in your practice, and how are you really trying to overcome that issue? Are you employing more nutritionists, or you stagger these patients? How do you do that? Because I find it very difficult.
So now in my hospital, so we have employed 2 senior dietitians and 2 juniors to them. So we are running a subjective global assessment. So in GI cancers, in other cancers, so I make a proformas. So we are getting evaluated, and that's how. So this is our nutritionist week. So last 7 days we have been doing outside camps also in the hospitals with the patient attendants. So the popularity, the acceptance has been, and you are right. So as Chandrakanth said, so for that patient, so I would advise for 7 days of admission, correct the albumin, get a rice stew or a TPN or a partial parental nutrition, and then I would give a carboplatin. So this is what has changed in last 5 years, I should rather say.
Right. So you're saying that with whatever resources you have, you are able to manage to a large extent the.
Yes. So since it's a private, so I don't know if in a government sector where the patients rush will be more, so it may be difficult. But yeah, I am able to manage.
You're able to manage, madam.
Yeah,
The question of mismatch in terms of numbers. You
I
agree?
think that's a very valid point, and I think screening can be a multidisciplinary approach. Even a nurse, anybody can screen. If a person is at risk, then he needs a detailed assessment by the nutritionist, so then he can get diverted. But catching the screening first, I think, is an important part. I think it's also your question, screening versus assessment.
That's correct. So madam, you know, showed that tool where you're just using 2 parameters to screen somebody, and then you decide what you want to do. Chandrakanth, every patient will ask for some tonic, will ask for some, you know, powder, protein supplement. What do? Do you say, go and meet the nutritionist, they will give you a prescription for it, or will you write something? If you're writing something, what made you decide that you want to actually write that?
So very true, sir. So this is the point why I am interested in nutrition, because
write what you want to write.
This is because I keep explaining about the disease, prognosis, chemo, everything. But at last, the relative always asks,
Correct.
what I can do is I can give him food. So the relative at least will take last 5 minutes, 10 minutes of my consultation for food. And I try and avoid saying whatever it is. So
what do you do?
So I will write a protein powder for the patient satisfaction, and I'm really not aware.
I was coming to that. How do you, just a moment, so how do you decide on that protein? I'll tell you how I decided. Nothing, very simple. When I was doing MD, Resource and Ensure were only 2 protein powders that were available. So whenever somebody asks, I'll ask them whether you're a diabetic, you've got kidney issues or not. Resource diabetic, Resource kidney, and Resource hepatic, and Resource. For me, and the same can be replaced by Ensure. Inky, Pinky, Ponky, father had a donkey, the first get Resource, the next gets Ensure. Very unscientific, I totally agree. But what happens is in the busy practices that all of you have, and you know, sometimes happens in mine also, this is what happens. And how do we really, you know, sir, you were already wanting to ask, answer. So go ahead with the answer to that, and then also what you wanted to say.
So I will try and answer your previous
Yes.
and this question.
Yes, yes.
So first step is that I want to discuss with my dietitian what I expect from them.
Right.
They should know what is my desire from the consultation that the dietitian has. Second is I will divide the patients into two categories. Those who have no comorbidities, they can be referred to the dietitian and dietitian's orders can be followed without my any secondary interference. The second is when the preliminary investigations are done and then I find that there is an electrolyte imbalance or a hemoglobin is low or the patient is going to get treatment like cisplatin which is going to specifically target the neuropathy and nephropathy. Then I write in my consultation note that I want you to pay special attention to 1, 2, 3. And these patients I expect to come back to me with the dietitian's report to advise to say whether I need to explain something more clearly or I want to interfere or change whatever they have said. And the third part, the last part is that we should now understand that like resource and ensure there are much more things.
Right.
There are specific products for cancer patients and there are specific products for cancer patients during different parts of their treatment. And I think unless, like Chandrakanth said, unless we know, our mind is open, unless we know what exists, we will not know what to prescribe.
So essentially they are part of the multidisciplinary team, just like you speak to your surgeon and your radiation oncologist very frequently saying this is what I think we should be doing, not you should be doing. So the dietitian should be part of that team to understand what each of these treatments will do to patients, even if I miss. And the other thing I like about this multidisciplinary care is what I miss is picked up by somebody, is picked up by somebody. So ultimately the patient gets everything that is necessary. So madam, let me ask you, in reality, how do you really decide on these proteins, supplements that you're actually giving patients?
So today there is a lot of science to the whole process. So we decide based on what stage of cancer it is, what kind of
So let's say if you look at curative versus
specific-
palliative, end of life, is your approach entirely different in all these situations?
Yes,
Very
and
good.
also organ specific, state specific, what is whether he is up for radiation, surgery. So all of that will determine what kind of nutrition actually goes in.
Okay, right. And also the clinical setting.
Yes.
In curative, you will probably have a slightly different approach compared to palliative, compared to end of life.
Yes.
Because the other problem that clinicians almost always face is even when patients are dying,
Yes.
attenders want something. I mean, from their standpoint, it looks very rational.
Yes.
For them, it's their kith and kin who is dying, who's not having anything to eat. While all of us know it doesn't make any sense to provide nutrition to somebody who is, who's got a few days or a few hours to live.
In fact, the
So it's
ISPIN
always
guidelines
that-
very clearly give each of these stages very
Absolutely. So-
specifically.
The last point that you mentioned about patient is dying and what to do. I think the most important thing for us is to tell the relatives to allow the patient to eat whatever he likes to eat.
Exactly.
And I think that's something we sometimes forget.
Absolutely.
And it has happened to me in my close family that they say, no, he should not have a samosa because that is too oily and it's bad for him. He's going to die next week here. How can you not allow him to eat what he wants?
Okay. That's a very practically important point. Many times I say, not necessarily only for somebody who's dying, let's assume that there is no comorbidities, nothing else that's going to complicate. Many times I easily say, let him eat because he doesn't have taste, it's difficult to swallow, not digesting, and then we make a big list. Sometimes it becomes very difficult. Dr. Shivshankar, these special diets are all over the place, WhatsApp, Google and everywhere. So what are your thoughts on this vegan, keto? In fact, there are 6 randomized trials running in glioblastoma, I believe, which I realized only a couple of days ago. Keto diet versus, normal diet or whatever you want to call that as, and then macrobiotic diet. No evidence in science to say that these actually benefit, but it's just all over the place. And I'm sure you're bogged down with questions from patients almost every day. How do you handle this?
To Dr. Senthil for this question, and I'll just go back 1 minute. I won't take much time regarding the screening what we discussed about. I had a valid point putting it over there, like we have issues with the screening with all the patients, and we have major hospitals without the dietitians and the qualified people. So if you can just imagine having a screening tool which is put across to the OPD where the patient can himself screen, And if he answers yes to any of these questions, for example, I'm going to put across only 3 questions. Have you lost weight? Has your appetite reduced or the pattern of diet has reduced? And do you have any chronic disease? Yes to any question, directly go to the dietitian. Why you want a scoring for that one? 0, 1, 2, 3, complicate the thing, you get the nurse, you get the doctor to do the screening. So I'm not in favor of any kind of a screening tool which will come with the scoring part of it. Yes, a patient sitting for the doctor, if he can read at the OPD level where it has been stuck up on the wall, yes, if he answers yes, directly the room number can be mentioned over it. So that I just wanted to mention it over there regarding that thought, because very well-known people are there on the panel. I think this is the right platform to make a valid point to take it home.
Okay.
The second part, what you said regarding all these fat diets, if you talk about, in recently published my book, we have considered more than 18 types of cancer diets, more than 18 types. People are confused, but ultimately, okay, what is the best thing is the low glycemic index and low glycemic load. That is the most liberal and the restrictive. Both words I'm using over here. That diet contains your restrictions as well in a considerable way, and it is very, very liberal for the Indian population to be followed. So I would advocate, rather than going for a keto diet, which is to the extreme, and patients find it very difficult to adhere to that one. Most of the keto diet research, if you see, they have failed, not because of the principle of the keto diet. They have failed because of the non-compliance of the diet which is being given. So that is where we have a little bit of reservation. But if I get a very highly motivated patient and who says, yes, sir, you can just go about it, I'm going to adhere to your keto diet to the extreme. I'm just want to come out of this. Yes, I would be looking out for such kind of patient who is highly motivated can go for a keto diet. But considering that we predominantly consume a high carbohydrate diet, so I would better go for a low glycemic index and low glycemic load with good amount of fiber and a good amount of protein sources for that. Of course, EPA, DHA and have their own role to play over here. So that's my take, Dr. Senthil.
Dr. Ritika, would you agree with that? If somebody is motivated enough to go on a keto diet, you would encourage them to do that?
Yes, sir. If firstly, I would clearly mention what all is in a keto diet, and if the patient is ready for such kind of diet of such kind of discipline, because each and every particular diet needs discipline. So if the patient is okay with it, and if I consider taking care of the medical condition, if he is okay, then why not? If the patient is okay, I would recommend.
Clinicians, your response to that, if somebody is ready for a keto diet or a macro diet or whatever that is, the dietitians are saying, so the dietitians are saying that if they get a motivated patient, they will actually ask that patient to go ahead with that. There's a lot of background science to it, but nothing has so far been proved in the clinic, right?
So can I make one statement?
Yes, madam. Quick comment.
It is generally said that these ketogenic diets always are characterized by around about 4:1 ratio of dietary fat to protein and carbohydrates, and they are considered to be high fat diets which are practiced for weight loss, and they need close monitoring. With improper methods, they can lead to kidney diseases, also with high cholesterol levels, osteoporosis, high palpitations, and so on and so forth. It can create problems for our patients.
And
so
also,
is it really ketogenic diets which are going to be helpful?
So and we also, sure madam, so and just sorry to interrupt. And
I would also like to comment over here. I'm Shilpa Thakur.
Oh yeah, sure madam, please go ahead.
Yeah.
Quick comment please, we are done with our time.
Quick one. So I got disconnected in between. So I won't agree with the point with that if the patient is motivated enough to go for a keto diet, then as a dietitian, and the cancer patient can be treated with this. And there are so many valid points being made by initially by madam also. And then if the keto diet is a kind of a thing that has been still been under monitored for, like there have been so many references still been going on, But it is only the Mediterranean type of a diet purpose where Mr. Shiv Shankar has also been commented that's a low into GI and low into sugars and high into fat. We cannot go with extreme with any of the macronutrient over here. It's a balancing about the diet, and we need to teach our patients about the correction of the diet. It's not about the patient is motivated for a fat diet and we can go ahead with that. And in a long run, we do not have much scientific data also to support for it, except for the specific few cancer patients.
Sure, because the first thing when somebody asks me, you know, as a parting comment, I tell them, especially if they're colon, endometrium, ovary, any hormone-dependent cancer, the most important I tell them is not to stop fat, avoid, cut down, and then here we are, you know, just turning it around and saying this is probably the most ideal. I'm kind of confused now, sir. Can you resolve that?
If you are treating a patient with cancer-directed systemic therapy, not all patients respond in the same.
Right.
Not all patients will maintain the dose intensity. In CML patients, imatinib, at the end of 1 year, it's only 50 or 60% doses are continued in 100% by patient. So also it's with the diet. We should not expect the diet to make the world of a difference in all patients. But at least we should start the process. We should give them the right guidance. Then ultimately it is up to the patient to follow it or not.
That's right, sir. I'm just talking about this particular thing. You're absolutely right that, you know, over time we have to tweak that diet issue. You know, you might like something, not like something, and then you come to a conclusion as to what's appropriate for you. I'm talking about this ketogenic or, you know, the specific diet studies.
So if you have gut microbiome which is affected, and we know the difference between right-sided colon and left-sided colon. So the transformation in the gut microbiome with specific diets is well known. And that is the principle of how you want to follow whatever diet you want to do. So whether it's a keto diet or a intermittent fasting or diet that contains prebiotic, probiotic, afterbiotic, the principle is that you have a purpose in mind. That purpose is to change the nutritional status of the individual, and that is how we want to do it. So that also applies to ketogenic diet.
So you're saying there's some science to it, but you have to be very patient specific and disease specific to apply it. Is that what you're saying?
So what I'm saying is that just as dose intensity, what we expect and what happens is different, so also we should not say that patients have to follow this to 100%.
Right.
Let them follow what they can do. Otherwise, they will not do anything.
So you're saying let's make some general rules and tell them, you know, within this framework you can try and eat whatever you're able to eat. Very good, excellent. So I think, yeah, Chandrakanth, point before we organizer will have the final say.
Sir, keto diet is good for weight loss, but it has not been replicated as you said. So it is not a standard diet which can prescribe up to now. It is still experimental. We would await further data on GBM before we recommend keto diet.
I agree. I belong to that group. You know, I would like to wait a little longer before I say, you know, depleting somebody of sugar is the best way to go forward, because ultimately that's where you're getting to, isn't it? Yes.
Yeah, most studies which have been come out are basically meta-analysis of a lot of this thing. Though we need prospective trials. We need people, half people having keto and half people having normal, and then we need the numbers. So it will take some time. So let's see. The question is still open.
Very good. So I think this is so we'll wind up. For me, everyone's responsibility means it's no one's responsibility. So I think it's very important to say the dietitian will take care of this, I will take care of this, and we should, you want to go there? Oh, we are done. Okay, business, right. So that everybody has to have some clear...
I just want to make a comment because we have so many oncologists. I think it's a very important thing for every oncologist to have a nutritionist on board.
Absolutely.
I think that takes care of a lot of
without
worries.
any doubt, any doubt.
I think there are still many centers where we are struggling to have a nutritionist.
Absolutely. For me, we need more.
The most important thing is overnutrition, because we see a lot of our breast cancer patients, they become obese during chemotherapy because they just sit and they eat. And those people also need to be referred to. I send all my patients to dietitians.
It's an ongoing process, isn't it? It's not one assessment, one you know, advice, and then you're done with it. It has to be just like they're coming to see us, you know, every 3 months
If I tell them they don't do it, but I send it to a dietitian.
Yes, it will be a good idea for them to see the nutritionist and so on, because they see the social worker, lymphedema, you know, so many things are happening. I think this is, so the point is that...
Sir, I can make one point is that the dietitian should be a part of a rehabilitation team. As I've already mentioned, Because once the patient comes to an oncologist, the onco nurse can guide to the dietitian, then to the other therapist, and this can, you know, become a mandatory work rather than saying that, you know, because the patient is also confused.
Right, madam. I agree. That's my concluding slide, that everybody has to be a part of this process. It cannot be only the dietitian, only the oncologist, and so on and so forth. Not necessarily a team called as the rehabilitation team. I think we should form a part of the main treating team, because we now know that it has a big impact on the outcomes and many other parameters that we're trying to assess. Oncologists should get educated about the fact that this is a specialist area, and that we cannot do this job properly. So we need to get more nutritionists up on our board and make sure that we have a team that is, you know, optimal to take care of all our patients well, so that their outcome is very good. Thanks so much, organizers, and we had a good time. Thanks so much.